Welcome to the Degrees of Health podcast, a podcast dedicated to your physical, social, and emotional health. Conversations that add life to your years and years to your life. Join us each week as we speak with world experts operating a wide range of disciplines, practices, and various degrees of health. This week, we had the pleasure of speaking with Dr. Tom Walters. Tom is an orthopaedic physical therapist and the author of Rehab Science, How to Overcome Pain and Heal from Injury. He's a lovely guy, and we had a lot of fun talking about pain, movement, prehab versus rehab, lower backs, and why it's vital we all move more. If you're affected by any injury or physical pain, I'm sure you'll get a lot out of this episode. With that, here is Dr. Tom Walters. Tom Walters, thanks so much for doing this.
Thanks for having me on, man. Excited to talk about all this stuff.
Yeah, me too. I mean, as someone who's had a lot of injuries, your book was it was really a joy to read. It really was. And there's so many bits I took, and there's actually a lot of things I've actually implemented since reading
That's awesome.
it. So it's, the mark of a good book is how much it changes your day to day, right? And by that mark, it's a very good book. With that, I thought it was an interesting place to start, is because I'd felt into this quite a lot over the years. What is the cycle of pain avoidance?
Oh, that's a good question. Yeah, so basically, and a lot of people, most of us have had some kind of pain or injury. And, of course, there's the physical side that goes along with that everyone thinks about, like, oh, what's causing my pain? Did I strain this muscle or hurt a disc? Or, most people, when it comes to pain and injury, they're thinking about their physical body and what's been hurt or injured. And but there's this whole psychological piece that isn't always talked about. And if you've had, not all pains are like this. Some pains aren't as scary, and you're like, oh, my Achilles hurts a little bit. I was running yesterday. You can put things together, and it doesn't create as much anxiety. But some things, especially pains that are deeper, like back pain is kind of like this, back and neck pain, and especially if it starts to go on for longer and longer days and maybe weeks of pain, people will start to have this, it will cause more distress and more just sort of more psychological stress and worry, anxiety, oftentimes fear. And so there's this fear avoidance model in physical therapy where it looks at people having pain. And then, in the physical therapy world, pain is, of course, associated usually with some kind of movement. And so then they will avoid those movements. And you just get into this cycle where then that avoidance leads to deconditioning in the body. It can cause more sensitivity in the pain system, and then they just have greater pain. So you get into sort of this negative downward spiral of fear, deconditioning, increased sensitivity, more pain, and it just kind of continues like that. And so it's actually very similar to a lot of mental health disorders are often like this. I often compare to, I had a really bad social anxiety for about 10 years and slowly got better, but during that time period, I was, of course, fearful of situations where I would have anxiety. I'd be anxious about them. And so my natural response, even though I'm a PT and I was talking to people about this all the time with pain, I wasn't thinking about it with this other symptom that I had. And my mom's a psychiatric nurse practitioner. You'd think I would know. But I was avoiding situations where that would be triggering for my anxiety. So I would because of that fear, sort of hide from them. So for me, a lot of it was based on eye contact. So I was always more comfortable in events outside where I could wear sunglasses and I didn't have to show my eyes to people. Or if I had to sit still and make eye contact, which we were just talking about, I started my own podcast. So it's like I'm literally doing the thing that used to cause my anxiety, and it's almost an intervention at this point because I realize now I can't avoid that, because if I avoid it, it would make it worse, become more sensitive, and pain is a lot like that too. So that's kind of just a story of how it relates. But yeah, it's kind of the idea that fear leads to avoidance, and then that can cause more problems.
Well, I think I didn't tie the two. It's a very interesting concept of, I guess, this like universal rule of thumb: use it or lose it.
Mm-hmm.
Whether it be social mechanisms to, I felt really inarticulate and socially a bit inept after COVID, just not doing it right. And
Exactly.
I think my own experience with I had my L5 vertebrae fused together when I was about 18. Sorry, about 16. Sorry, and off the back of that, I avoided so much that previously put a lot of strain on my back. And when I was reading about the deconditioning in your book, about, I guess it's sort of atrophy or muscles deteriorating around it, the said injury, that can lead to actually further injuries down the line. I'd love to get your 2 cents on that, because it felt like this very real cycle I had been in a couple of times with my shoulder, my back. And I know other people listening probably relate to it, but how does one injury and the lack of right rehab and interventions cascade to further sort of harm and movement issues?
Yeah, it's such a common one with low back pain, whether someone's had surgery or just something that, again, I think because that we have research showing that when an injury is deeper, where you can't see it on surface level, it tends to cause more worry in people, and they will be more likely to have these kind of fear avoidance type behaviors. So like if you cut your skin, you can kind of see like, oh, that's why it hurts. I see that right there. But something that's really deep that you can't see tends to make people worry more. And and so you'll hear this a lot with back pain. And oftentimes, unfortunately, people also get these kind of messages from medical, maybe some rehab practitioners, like, oh, avoid that. Don't squat anymore. Don't deadlift, and right. Every person is different. Every person's pain is different. You have to look at each person on an individual basis. And sometimes people do maybe require some modifications so that they're not constantly flaring up whatever pain they have or just letting something heal. So it's not to say you can go out and every single person who's had a back surgery or pain could just start deadlifting right away. But most things you can get back to if you just progress gradually. It's kind of like using progressive overload with weightlifting, where you slowly put more weight on to get stronger. You're kind of doing that with the physical body. It's almost like this graded exposure kind of mindset where you're slowly building on stress to make the system more resilient. And the question you were asking, if you don't go through the appropriate rehabilitation steps, you do see that impairments can persist. So because basically when people come to physical therapy, we're looking for impairments in their physical body. So it's looking at things like, do they have mobility restrictions in their range of motion, whether that's can they move their shoulder through full flexion on their own? And then can I lay them on the table and can I passively move their shoulder through full range of motion? So those are mobility type impairments. We look at strength impairments. Can they resist, side to side? Are there asymmetries in strength? Motor control, what's sort of like coordination, what's the quality of their movement look like? Balance impairments. So we're going through and looking for those types of impairments. If you don't address them, say you have had back surgery and injury, yeah, you could have deficits. One spot in particular that we look at are the lumbar extensors. So those muscles on your low back, they do the opposite movement of your abdominals. So everyone thinks about their core or their abdominals, but you have these big lumbar extensors on the back side of your spine. And those often atrophy when people have back pain or have had back surgery. So if you didn't have specific kind of therapeutic exercises to address those muscles, they could remain in a weakened state. If you are fearful of moving and end up avoiding certain movements, you could lose mobility potentially in your lumbar spine, in your low back, maybe even in your hip joint. We see a lot of things go over to the hip because it's the next adjacent joint. And so sometimes people will avoid that joint too. And so if you have impairments, maybe it's a mobility impairment, maybe it's a strength impairment, you are going to compensate in some way somewhere else in your musculoskeletal system. And that usually means that certain things are being underloaded and other things are being overloaded. And, that just sets you up for maybe future kind of pain issues or maybe potentially another tissue injury somewhere else in that kinetic chain.
Sure. So the really interesting, I guess, one of my biggest takeaway from your book was it summed up in a line, which is prehab is rehab.
Mhm.
And I'd love to get your thoughts on that, because it seems it's aligned with this whole preventative over reactive health, but specifically when looking at the body.
Yeah, it's a point that I'm trying to get across all the time. It's tricky for me because my book is called Rehab Science. So because of that title, people are naturally going to think everything is only reactive. That those exercises in the programs are only things you would incorporate once you already injured or have pain and you're going through the rehab process. But the truth of it is the physical therapy exercises really revolve around mostly mobility and strength exercises. And those are all things that if you do them before you're injured or have pain, they keep you mobile and strong, so you're less likely to have pain and injury. So a lot of the exercises in those programs are things I just do at the gym normally just to kind of keep healthy. So yeah, there is that is a huge element. We have a lot of research on it now, especially with surgical conditions where if people perform kind of prehab programs, which are basically just taking the rehab program and doing it beforehand, a lot of the similar exercises and movements, once they have surgery, they recover much faster than the people who didn't do those things before surgery. So, it just yeah, it really is kind of that constantly trying to get that message through of a lot of things you would do in rehab. If you do them beforehand, you're less likely to have an injury. And if you do have an injury and you go through rehab, just keep those things in there a couple of times a week just to try and reduce the likelihood that it comes back.
Okay, so I love that. I mean, I remember reading I think it was an Outlive Peter Attia's book, where
Mm,
most falls in sort of older elderly people, that kickstarts the inevitable decline into,
mhm.
being immobile. I can't do the things I love. Knock-on effect to my social interaction. So upstream of all of this is actually how you move, right? So how do we make sure we have the right sort of prehab protocol? Like, what is the sort of foundational movements we should be doing on a daily basis?
Yeah, and I just want to touch on that last point. Falls are interesting that we were talking about fear avoidance, that fear avoidance model. Falls have their own a fear of falling. So after people fall, there's this whole area of research looking at a fear of falling afterwards and the tendency for people to become more sedentary and deconditioned. And then when they do get up, they're more likely to fall again because they've been
Uh,
sedentary and become deconditioned. So falls are a huge problem, especially in the older population. Especially you look at hip fractures and the number of people that die within a year after hip fractures from falls. It's a major problem. But a lot of that you can combat with these kind of programs where you're looking at therapeutic exercise programs where you're improving strength and mobility. Um, when you're thinking about fundamental movement patterns, a lot of it is actually very similar to physical therapy, and the strength and conditioning world have a lot of crossover. And so a lot of the patterns, that you would look at in terms of, because this stuff can get kind of complicated and sometimes people are like, well, where do I start? And I think sometimes, I taught kinesiology for 10 years at a college here in town, and I think kinesiology is the study of human movement. And I think when you look at, sometimes the best place to start is just to kind of understand the movements that are possible in your body. And there are different planes of movement. So we have the sagittal plane of motion, which is kind of the forward and back plane of motion. It's kind of what most of us do, like when you're walking. It's all the flexion extension movements. So that's the sagittal plane. Most of us spend most of our day in the sagittal plane. Bending over to pick something up is lumbar flexion. That's a sagittal plane motion. Like I said, it's kind of that walking, going up down stairs, all that stuff, squatting, all those things are sagittal plane. And then you have the frontal plane, which is side to side. Those would be all of our, like, we call them abduction, adduction, like bringing your arms out to the side or your hip out to the side, bending your spine to the side. Those are all frontal plane. And then transverse plane is the last one, and that's rotational movement. So that could be rotating your spine. Your ball and socket joints, both your hip and your shoulder, both have internal and external rotation. Turning your head side, or looking over your right and left shoulder is rotation of your cervical spine. Those are the three planes of motion, and then there are just movements that go along with each of those at each joint. And I think there are some that are more important than others, but if you kind of just have a general understanding first off of what are the planes that we've got, these three planes of motion, and what can my joints do, and you can look this up online. You can just look at the movements that are possible at each joint. And if you really want to get scientific about it, just like try to have a movement, like try to build those movements into your program throughout the week. So but I think if you're thinking about just fundamental patterns and where you start, things like squatting, being able to kind of to deadlift, we call that a hip hinge, where you can flex your hips but keep your spine sort of neutral. It's like they call that it's being able to kind of dissociate your low back from your hip joint. So can you bend over and kind of keep your back straight? Um, a lunge pattern. I think, when you look at the upper body, being able to do things like pressing overhead. Can you do sort of like a horizontal kind of pulling, like a rowing type movement? There's, horizontal kind of pressing movements. It's a bit like people would do for like push-ups and rows. And so it's like you've got squats and lunges, deadlifts, pushes and pulls. There's, like I said, there's so many different, you have so many different joints, and each of those joints can move in different planes of motion. And so this stuff can, if you don't have a background in it, you can kind of get overwhelmed pretty quickly. But I think maybe it's unfortunate that people don't learn more about their movement system in school. It's
Mm.
just certain things that we all have this body and we don't learn. But it seems like kinesiology, the study of human movement, should be kind of a core course that everyone should be required to take.
But I think sometimes it needs a why, right? And
Mm,
it's a very easy why if you're in pain to
sure.
fix something. But without the pain, you can't see what's going down the line. So
Mm.
how do we give people a why to incorporate all of this in? I think that's when it's missing.
Yeah, no, I agree. It is hard. It's hard with these things that you if you don't have, like you said, pain and injury, they're great motivators. And if you don't have those, it is hard if you're really healthy to imagine kind of down the road and some of the decline that naturally happens as you age. It's hard to be motivated by that when you're young and feeling good. So it I think, and maybe I know this was true for me when I was in my teens and 20s before really having pains or injuries. A lot of it was performance focused. So I think the why, maybe when you're younger, for a lot of people is, well, learning about those things and how each joint moves and exercises that target each movement, that can boost performance. And then as you start to age, I'm 42 now, I can still do a lot of things I could do when I was in high school, but I'm slower to recover, and things do get tweaked more easily. So I'm kind of in this transition phase in life of caring some about performance still, but also thinking about the longevity of my system and the health of my system. So my why is kind of changing, but it is tricky if you aren't in this field. For me, I worked in nursing homes, skilled nursing homes for a while in my career, and I think when you see people who permanently live in these facilities because they have impairments that make it so that they can't leave, they can't be discharged. For me, it's really easy to have a why for why I
Mm.
need to keep my musculoskeletal system healthy. And maybe people can think about that, like with an older, like a grandparent or something like that, that maybe you see them struggling with certain movements or tasks in their day. And that can be a major why. If you continue to work on your mobility and your strength throughout your life, you're less likely to be functionally limited as you get older. Maybe like you see a grandparent, um, how they're functioning in your own life.
Yeah, I completely agree. And actually, for me personally, that's definitely come about the last couple of years. Just you take it for granted in your early 20s. You can
Hmm.
do anything, and you don't have to warm up so much. You don't have to cool down, and suddenly it catches up with you.
Yeah,
And
for sure.
yeah, I'm in that kind of transition period now of, okay, part of my everyday, I need to have some sort of rehab protocol that keeps my body right, so I can sprint and run and do jujitsu and all these things. Otherwise, I'm actually just not going to be able to do them.
Yep.
Game over. Um, it's interesting. So w- before we I want to get into the pain thing, because pain obviously will hinder movement, right? Or can. What are the three
Hmm.
types of pain?
Yeah, these are good for people to know because they can kind of help you figure out. I had have a whole chapter on this on types of pain because they do give you some direction how you move forward. And so the one that's most common, probably that most people are dealing with, is called nociceptive pain. It's the most mechanical type of pain. It's the one most associated with the tissues in your body. So like if you sprain your ankle, um, you have these if you hurt something in your body or you apply sort of like we'll talk about sort of like a high threshold stimulus, even if you pinched yourself, right? And you squeeze your finger, as you squeeze harder and harder and harder, at first it just feels like pressure, but eventually you activate these things called nociceptors, which are danger receptors, and then they shoot a message up your spinal cord, up to your brain, telling your brain there's danger. And we know from the pain research that pain is an output 100% of the time of the brain. So it's not to say that it comes from your head, that it's made up, but it's created by your brain. It's a descending kind of output from your brain. And so if you keep squeezing, eventually you'll probably feel pain. And so that would be a type of nociceptive pain because you're activating these danger nociceptors in your tissue. And so again, that's most things that people will encounter: ankle, like ligament injuries, ankle sprains, if you tear your meniscus, if you strain a muscle, things where you can connect a mechanical kind of stress to the development of that pain. Like, oh, I went running a lot yesterday, now my Achilles hurt. Like there's a clear linkage. nociceptive pains are easy to kind of turn on and off with different positions or movements. You can trigger them easily. Like, oh, if I turn my arm out this direction, it causes that shoulder pain. But if I get out of that position, it goes away. So they kind of stay in the same area. They're easy to turn on and off with very obvious mechanical triggers. And then you have neuropathic pain, which is actually very similar, but it affects our nerves and not our. So it's all it's um, it's affecting neural tissue, not all the other ones like ligament, connective tissue, muscle, tendon. So like when you hit your funny bone, like you hit your ulnar nerve on the inside of your elbow, that is a neuropathic pain. It's an acute neuropathic pain. So other ones are sciatica. Anytime you have radiating kind of traveling nerve pain, like a lot of times we hear it with neck and low back pain, but usually it will that's one of the hallmarks. It will travel down one arm or one leg. It might burn or tingle, cause numbness, might feel like a lightning bolt, things like that. And then the last one is chronic pain, which more so we call it persistent pain now because that chronic name has a really negative people kind of hear that and think I'll never get better.
Quite a
So the
spooky
name,
term, that.
yeah, it's so it's been changed. Most of the time now you'll hear persistent pain, but that's a pain where it's been there for a while. Technically, it has to be longer than 3 months, even though some nociceptive pains can definitely last. Some tissue injuries in the body take a year to heal. So the chronic pain is a little bit different in that it has to be there for a certain length of time, and it starts to change where you can't activate it as easily with mechanical things. It's kind of unpredictable. It might spread, things like fibromyalgia kind of fall into that. And there's a bunch of different categories. There are chronic pains associated with cancer. There's headache type ones, some after surgery. So you hear of different ones like that. One other pain that isn't the three main that we always talk about is referred pain, which is pain that comes from an organ that you might feel it feels like it's a musculoskeletal pain, but it's actually coming from an organ. Like the kidneys are a good example where kidney infections can cause low back pain. And sometimes people think they have a low back problem, but they can't trigger it with any back movements. It only hurts when they urinate or something like that, or digestive type pains where they only gets triggered when they eat, even though it might feel like it's a spine pain or something.
Yes, that I can relate to that. I remember I had something my kidneys like a decade or two ago. I was like, my back is just in pieces here. This isn't good. But it's interesting. I think it's a really good reference point to have those locked away because you can better identify what's going on in your own body. You've seen thousands of patients over the years. What's the most common type of pain, and where does it come from?
The most common, this is kind of what the goal of the book was to distill it down to the most common because most humans really do follow a lot of the same patterns. I've been practicing for 17 years and you just start to see most people are going to have probably the 15 or 20 same musculoskeletal problems, and I put 50 in the book because there are other ones, of course, but it's back pain, of course. If there's an 80% lifetime prevalence of back, 80% of people are going to have back pain at some point in their lifetime. So spine pain is really high. Neck pain is kind of after back pain. But then you're looking at low back pain as the primary type of pain. And then after that, really you're looking at neck, shoulder, and knee type conditions. Those are probably the next big three. And a lot of times it's really important that people know that pain and injury aren't the same. They are different things. Injury is a physical tissue injury, like an ankle sprain. Something traumatic happens. You tear a muscle, you strain a muscle, you tear a ligament, tear your meniscus. Those are all technically kind of injuries where you can identify something has happened to a tissue. Pain is different in that you can have pain without an injury. You can have an injury without pain, right? Like they're different. They're just different items. And a lot of the things we see in physical therapy, especially you start talking about low back pain, neck pain, lots of different shoulder and knee types of pain, often are just pain conditions where you can't actually identify an injury. I mean, my post today was on the patellofemoral joint, which is your joint behind your kneecap. It's really one of the most common sites of pain in the body and probably the most common type of knee pain that comes into physical therapy. And there's no injury there. It's just that the joint behind the kneecap gets irritated. And then people have sharp pain in a lot of cases with things like squatting, going up and down stairs, if they sit with their knee bent for too long. But if you did an MRI or an X-ray, you wouldn't see anything. But they have pain there, and it's a a lot of pain states are like that, where you can't actually identify anything on imaging, but the person definitely has real
So,
pain.
so what causes I mean, if there's no injury, what causes the pain?
Yeah, in a lot of cases, it's a stress, like a new stress. So the system was stressed either with something new or more of something that maybe it was something they were accustomed to, but the volume of it was higher. I mean, actually, that's most things in physical therapy.
Really? So when you say system, do you mean like the specific knee joint or the specific shoulder joint or?
Yeah, sorry. Yes, exactly. Yeah. Like, so if somebody comes in with that kneecap kind of patellofemoral joint pain, usually what happens is like, I just had someone the other day, they moved into a new house that has more stairs. And so they've got to climb stairs all the time. And so it isn't that they've injured something, because in most cases, it's the stress that's being applied to that area is actually not, it's lower level stress, like climbing stairs and things. That's not going to damage any of your tissue really, but it might irritate something if your body's not used to doing that. I mean, I'm always trying to help people understand your musculoskeletal system is extremely resilient and robust, and but it takes time to adapt. It has this great capacity to adapt, but it takes time. I mean, again, that kind of goes back to, I always like to apply it to the idea of weightlifting and progressive overload, because if you slowly add weight to the bench press bar when you're in there, right, you can add more weight over time. Your body adapts, your bones become stronger, your muscles become stronger. It's true for other things in life that we might not think of in the same way, like climbing stairs. Like if you have to climb more stairs, well, I mean, this sounds silly, but if you knew you were moving into a house with 2 or 3 flights of stairs, well, you might start a program before you move there of adding more stairs to your workouts and your daily just life to build that capacity up so that when you do actually move, it doesn't cause a problem. But we don't ever think that way, right? It's just
Mm.
always this kind of reactive, and I think people aren't educated on it, so you can't blame them for not thinking that way. But your system, your musculoskeletal system has a great capacity to adapt, but it does require some time. It's kind of a gradual thing. And so a lot of times what happens is people just add some new stress. Or the other one I hear a lot is people go on vacation and they do way more walking. Like they go to Europe and they walk a lot, and then they get plantar fasciitis or something. And it's not like they had an injury. It's just they irritated that tissue because they've loaded it way more than it's used to.
Okay, so too much too soon. So I guess that's another argument for a protocol that sort of keeps you level all around, where
Hmm.
there's less surprises in your trip to Europe or whatever it may be.
Yep.
Um, okay, so with those types of pain, what are the most common injuries, I guess, you see?
Yeah, I would say, ankle sprains are one of the big ones. In the US, it's something like 15,000 ankle sprains a day. There's a lot
Really?
of It's crazy. There's a lot of ankle sprains. And then when you look at actual injuries, it can get a little bit tricky because sometimes, well, right off the bat, I'd want to say, oh, things like disc herniations and disc bulges in the low back and the neck, meniscus tears in the knee. I would say there are labral tears in the hip and shoulder. The tricky thing about those is that we've seen in the research is that about half of the population have those who are pain-free. So we're a little bit more careful to call those injuries now because sometimes they're just part of the normal aging process. It appears that like your meniscus, your rotator cuff tendon, you have 4 rotator cuff muscles. The one that most people tear is called supraspinatus. The muscle's called supraspinatus, and its tendon's kind of on the top of the shoulder. So people will feel pain kind of at the top of the shoulder, sometimes down the side of the arm. But what's interesting is about 80% of 80-year-olds have a tear in supraspinatus. So it tends to just occur, a lot of these things just occur as you age, and some people develop pain and some don't. And I think that's where pain can get complicated. When I was a new physical therapist, I would have called all those things injuries. I would have called disc bulge. Oh, if I saw a disc bulge on an MRI, that was an injury. Or if somebody had a meniscus tear, that was an injury. But now, so many of these things are just degenerative, are just associated with aging, kind of like getting wrinkles.
Mm,
Those are just, we don't think of wrinkles as some dysfunctional problem. It's just part of the aging process. And I think there's a lot of these kind of internal wrinkles almost that are happening.
yes.
And if you go and have an MRI, they can kind of freak you out because you can see that. And if you have pain at the same time, it's easy to blame that as the source of your pain, even though it may not be associated and just be a part of the aging process. But there definitely are people where those things cause pain. And I would say they are, if we were talking about some of the more common injuries, those are probably the things you're talking about. You've got like ankle sprains, ligament ACL tears, things like that, meniscus tears, shoulder dislocations, rotator cuff tears, and then all the kind of disc bulges and all those things. If you did an MRI, you could see them.
Yes. Okay. So it seems like, and correct me if I'm wrong, that most people don't move enough, right? People sit for 9 till 5. We don't walk half as much as we used to. People are indoors more than ever. That must have a knock-on effect to, I guess, injuries in our life and stopping us doing things we love to do. What effect do you think the modern environment has on our body, and how can we offset the modern strains? So, for example, why is sitting so bad?
Yeah.
What effect does that have on our bodies?
Yeah, it's a major factor. It just you are slowly declining, your musculoskeletal system. I keep using this word capacity, but it's basically the capacity to deal with stress that's put on it. And so your capacity is decreasing if you are sedentary more often. If your system is not going to waste energy maintaining muscle mass, tendon strength, bone mass, all these things will go down. This is another area. It's not just me making it up. We have studies on this and people who are bedridden in the hospital and how fast their system declines. Every area of their system, organs, the musculoskeletal system, but even just with a week of bed rest, how much bone density drops, muscle mass drops, tendon thickness, all of these things. Your body just isn't going to spend a lot of energy maintaining muscle mass and bone density if you don't need it. So this is also what's happening to some degree when you are sedentary for hours upon hours. Your system is going to lose some of that capacity. And then when you go to want to put stress on it, this is the whole weekend warrior concept. You've heard, yeah, it's like people, they sit at jobs, and because they're moving less and probably eating the same amount of food or maybe more because they're bored, maybe they put on some weight too, their tissues become deconditioned. And on the weekend, they go to play a pickup game of basketball and rupture their Achilles tendon. So you have this, you have a bunch of factors coming together there, but sort of the major is that they're putting stress on that tissue again, say on their Achilles tendon. They go to change direction quickly in basketball or something, and that thing ruptures because they haven't been stressing it. They haven't been giving it kind of the necessary stress at frequent kind of regular intervals to maintain the tissue integrity and strength. And then when they do put stress on it, it's more likely to fail. Your musculoskeletal system, we try to get away from comparing it to a car, but there are some mechanical components to it. And I think muscles and tendons are the easiest to understand because, of course, like when you lift a weight or you use that muscle tendon unit, it gets stronger. So it's more resilient. It's less likely to fail. If you try to stretch it, they do these kind of experiments where they'll put a muscle tendon unit in kind of a vise on two sides and pull it until it ruptures. And they look at how much force in newtons did it take before that tissue failed. And so if you are regularly using an area of your body, a particular muscle, if you tested it like that, it would take more force for it to fail versus if you take the sedentary person, if you go to test theirs, it will fail much faster. And so I think there is this, even though our musculoskeletal system is much more complicated than a simple machine, there are mechanical principles. That's why there's this whole area of biomechanics that's studied in the human body. And so you have to, it is so important. This is why strength training, resistance training is actually the primary intervention used in physical therapy. It comes towards the end of the rehab process, but resistance training, every good physical therapy program should look like a resistance training program at the end, because strength training strengthens all of your tissues, not just your muscles. And that means you're less likely to have an injury.
Okay, that makes a lot of sense. I guess it sounds like sort of the optimal protocol should be something like you're stressing your body in lots of different ways over the course of a week, so that as and when you get exposed to a stressor, it's not stressful because your body's quite used to it.
Yeah, you just want to be prepared. You want to, it's sort of like a readiness type of program. You want to, you can't predict everything. You encounter things that just happen. I mean, injuries are inevitable. Sometimes you step off a curb and sprain your ankle. You can't really train for that. or something, you have to catch something or grab something heavy really fast and you strain your back. Like sometimes things just happen. You can't prepare for everything, but I do think this is where going through and sort of making sure, like asking yourself, do I have the mobility I need for the tasks that I regularly encounter? And do I have the strength and motor control, that coordination to be able to generate the force I need to accomplish the things I need to do in my life? And do I have the control so that I'm not unsteady or feeling unstable and risking injury? Those are kind of the big ones. Like, what's my mobility look like? What's my movement control look like? And then do I have the strength? Can I generate the force to actually do these things?
Yes. Okay. So specific to yourself, Tom, what do you do personally? What does your movement and mobility program look like?
Yeah, these days I grew up as a martial artist and a gymnast, so I didn't realize how powerful those sports were in high school. How much I learned about movement awareness and mobility and balance and strength and things like that. So nowadays, I really just focus on resistance training. I love martial arts. I used to do jujitsu. I ended up quitting jujitsu because the injury risk there were just things I couldn't control.
Mm.
And as much as I love jujitsu, and I just, people, there's scrambles and you can't control the other person. And sometimes you get people who they're just not, they're wild and you get injured.
It's the knees that worry me with that. I mean, I want my knees to be good. I don't want my knee lock or anything there.
Yeah, tear your meniscus. You hear a lot of knee injuries in jiu-jitsu, right? It's like
Yeah.
heel hooks and different things where, yeah, there's just but nowadays I really kind of focus on I am probably annoying sometimes that I'm thinking about injury risk all the time and saying no to things because I'll just determine the injury risk is too high.
Yeah.
But most of my workouts now really are I like going to the gym and lifting weights, so I just do that. I mean, I never get very big, but I kind of always want to maintain that gymnast kind of body. Like I just want to be mobile and strong with my body weight. That's always been my goal. And so I go and I almost follow kind of a bodybuilding program in some ways because bodybuilding programs are actually really good at isolating joints and movements. And so I don't focus on, it's not like I'm in there doing a lot of bicep curls or things. I'm doing a lot of compound movements like squats, deadlifts, lunges, shoulder press, different types of presses, horizontal, incline bench press, rows, pull-ups. So I do a lot of the like kind of almost common weightlifting exercises. If you go to the gym and lift weights, my program would look just like any other kind of normal weightlifting program. But in my mind, I'm thinking about, am I kind of targeting the different planes of motion and those fundamental movement patterns we were talking about before? And I think a lot of times those compound movements are the best option. Compound movements are they're exercises where you're moving multiple joints at a time, like a squat. Like your ankle has to move your knee, your hip, your spine, versus just doing like a bicep curl. Now, I mean, doing a bicep curl has its place sometimes because sometimes people get like biceps tendinopathy and where they get kind of like a tendonitis in their bicep tendon. And we know that like preacher curls, different curls can really help that get better. And that's where specific therapeutic exercise is important when you have a specific injury or pain problem. But if you're just kind of healthy and looking at preventing injuries, then I think you're thinking a lot about resistance training exercises that take you through a full range of motion and are compound in nature, so they move multiple joints, like a squat and a lunge and things like that.
That's a really nice, refreshing answer to hear because I, like you, a very similar, I guess, sort of program. And I found that's, whether it's using bodybuilding or whatever, it's a very well-rounded approach for a lot of things. A larger muscle has more potential to be a stronger muscle. It covers all the whole body. There's no blind spots with it, right? And I like that. And it's refreshing to hear that there's not some obscure exercise I've never heard of that I have to suddenly master to be able to run into my 50s and 60s, right? So that's nice. Do you get that a lot where people are looking for some sort of obscure thing they're not doing and are frequently disappointed when it's just the basics? Or
Yeah, actually, people probably more often have the opposite response to you, where they're sort of disappointed that it's not something fancy. I mean, my whole Instagram feed focuses around the basic exercises. Like, it's just these are common conditions and these are the exercises, and they're just a lot of times basic exercises, like people doing bridges and squats. And I mean, sometimes there's something kind of unique. Like, of course, in physical therapy, sometimes there's a unique, okay, we want to this person has, pain on the outside of their hip. It looks like they have gluteal tendinopathy. We're going to do this side-lying hip abduction. It's very specific to targeting that tendon. But most of the time, that stuff is used. Some of those really specific exercises are used in a window of time at a certain point in the rehab process. And then as the pain dissipates and the person gets better, they go back to these big compound kind of fundamental movement patterns, So I think the other thing that maybe people can think about too for staying healthy are unilateral movements, maybe where you're on one leg, especially with the legs, because sometimes if you just do double leg squats and deadlifts and things all the time, you can hide little, um, I don't want to say like weak links, but you could hide little strength impairments and control impairments. So a lot of times, the single leg exercises are nice because you don't need a lot of weight, so you're less likely to injure your back. You could do like a single leg squat, just holding a dumbbell in the opposite arm, or a single leg deadlift like that, or a single leg hip thrust, single leg bridges. There's so many of those that are good at, you don't need as much weight to get that strength effect, and you also can find any little strength or control impairments that might exist. Whereas if you're doing on two legs, the other leg can make up for it and you can hide it.
Definitely. The yeah, it's something I need to do more of. I mean, again, with my back thing, I stopped barbell squatting on my back, and then as a result, tried to do lots of lighter things, a lot of lunges, a lot of sort of single leg split squats things. But I'd like to get back to sort of back squatting, especially after this conversation.
Yeah.
And yeah, it's that approach of, I guess, just progressive overload over time and building it back up as opposed to trying to go too fast too soon.
Exactly.
When it comes to, you mentioned muscular imbalances, I think, or maybe I'm paraphrasing slightly, but weak points in the human body. As like a collective culture, where do you see these weak points most often?
Yeah, they're actually usually they're usually in planes of motion. We were talking about the 3 planes of motion earlier. They're usually outside of the sagittal plane. So the sagittal plane was that forward and back kind of plane of motion. Usually, a lot of times the things we're addressing in physical therapy are in either the frontal plane, or which is that side to side plane,
Okay.
or the rotational transverse plane. So you might think of, like I was mentioning, gluteus medius a second ago. Gluteus medius is this little hip abductor muscle that's underneath gluteus maximus, like that big butt muscle everybody's used to thinking about. Gluteus medius is a hip abductor primarily. It brings your hip out to the side if you're just standing, but in function, it helps to keep your pelvis level when you're standing on one leg as you walk. So we see issues like with that muscle, gluteus medius and gluteus minimus, the one underneath it. The rotator cuff muscles, are a big one because one of their major functions is to keep your shoulder stable, to keep the ball in the socket, but they also rotate your shoulder, so they move in the transverse plane. So you'll see a lot of people will be familiar with the band exercises where you turn your shoulders out, internal and external rotation. But that is a weak spot for a lot of people. Most people don't specifically strengthen their rotator cuff muscles unless they're injured. They have a rotator cuff tear, they just had rotator cuff surgery. So that's one of those ones. I don't keep a lot of, even though I prescribe a lot of these specific kind of rehab therapeutic exercises to people, there aren't a lot that I'm doing myself on a regular basis. But there are some that I'll keep in there from time to time. And the rotator cuff ones are an example. The gluteus medius exercises where I'll lay on one side and kind of do hip abduction. Single leg bridges are good exercises for that muscle group as well. Calf muscles, like your Achilles tendon in your calf. A lot of people skip calf raises, but calf raises are really important for keeping your gastrocnemius and your soleus, those two calf muscles, strong, and the Achilles tendon strong. You're just less likely that anybody who has an Achilles tendon pain or has ruptured their Achilles tendon, we're going to give them lots of calf raises. So, I think there's a lesson in that. Like if you're getting a lot of this exercise in rehab, it's probably good to keep that around when you're better. So that's a big one. We were talking about the low back extensors before. That's another really important one. If you have any tendency to develop low back pain, lots of research showing that strengthening the muscles of the posterior chain, those low back extensors, the glutes, the hamstrings, can help kind of reduce your risk of developing back pain.
So something like a deadlift or like a
deadlift, or like Superman's, like where you lay on your stomach and kind of arch up, kind of lift your legs and your or like the there's the reverse kind of hyperextension machine in the gym where you hook your legs in and kind of lift your trunk back. It's like the opposite of a sit-up kind of.
Yes.
Hip flexors are another big one. Like hip flexors, a lot of people don't strengthen their hip flexors. A lot of people will strengthen their glutes, which are your hip extensors, but you have to think about the antagonistic muscle. So a lot of times we'll take these little loop bands and put them around people's feet and kind of do these marching exercises where they have to work their hip flexor on the front of their hip.
Okay. Yes.
So there's little ones out there. There's lots of little muscles like that I think if they got sprinkled into your program here and there, it'd be pretty helpful.
Okay, nice. Again, it's refreshing that you don't have to completely take up a new program of, all these obscure movements, and actually just a lot of the basics repeated over time will do a lot of good.
Yep.
What I'm trying to resist the urge to ask you about a reverse hyper, but I can't. So, does a reverse hyper have a place somewhere, or that kind of movement pattern?
Yeah, I mean, I think just because of how much you use your lumbar extensors in daily life, anytime you bend down and pick something up, those lumbar extensors and glutes, that whole posterior chain is going to kick in. So there's definitely a place for reverse hypers. I mean,
It's an
honestly,
obscure
there are
machine,
some
right?
it's just a good machine. Yeah, I mean, just strengthening that posterior chain is oftentimes the most helpful thing with people who have had back pain, not in the acute stages, because sometimes that extra compression just triggers them, but as their pain kind of gets better into the later stages of rehab and for preventing back pain reoccurrence, strengthening the posterior chain with a machine like that is oftentimes one of the best things you can do.
Okay. Just for the listener, a reverse hyper is a very hard to find machine in the UK, and only a couple of gyms have it. And when it's there, I always make a beeline for it because in my experience, it's been very good.
And you're talking about the one you normally see. It's the one where you hook your legs in. It's a solid machine. You hook your legs in and bend your spine up,
So
kind of over it
it's
and back up. Or are you thinking of the other one where
the
it
other one
moves?
where your
Yeah.
torso is on and your legs
Yes.
come down and you pull it back up. It's sort of like a
Yes.
reverse way. I don't know if that makes
Yes.
sense.
Totally. I can't. I'm actually calling the one I'm talking about the wrong name. I can't remember what it's called now. Oh, well, it's like the one I'm talking about is just a pad. Your lower body's fixed and you bend forward
Yeah.
over it, and your body's moving, but the machine doesn't. The one you're talking about, both are good though, because the reverse hyper, the one you're talking about, where your kind of chest is stabilized and you're extending your hips backward, is going to get back extensors, and hip extensors get your glutes as well. So it's another great posterior chain strengthening one.
Okay, cool. This is good. I'm taking mental notes of what I'm going to do this evening in the gym.
It's probably a good one for you actually as you build back towards, I don't know if you're deadlifting now, but with your back history, even going back towards back squats, that's a great preparatory strengthening exercise because you're targeting that posterior chain, adding stress to it, and then it's just gradually moving. If you want to, you don't think you have to go back to back squatting, but if you want to, then you just gradually start adding that back in with light weight and build up.
Definitely. I mean, it's getting there, taking a bit of time, but
Yeah.
still diving into your book, and I'm sure I'll learn loads more. What is tech neck?
This is one of those ones that's I am guilty of doing posts on this because it gets a lot of engagement, but it also annoys me at the same time. Yeah, I mean, tech neck is this idea that we're all looking down at our phones usually, and so you're maintaining this neck posture where your head is in this flex position. All of your neck muscles have to sit there and hold your head as it hangs down like that, and yeah, I mean, for some people that causes pain, but it's not really that position is necessarily the position is bad for your body. It's just that you're there for too long. Most musculoskeletal things, we've realized over time that there isn't really good and bad posture. There's just postures that you're in for too long. And so sometimes you have people who have back pain that when they slouch, they feel better, and when they sit up really straight, their pain comes back. And so, but once upon a time, we would have said, oh, if you sit up straight with your shoulders pulled back, that's good posture. And that's what you need to do. But the truth of it is, any posture can create pain if you're in it for too long. And so the tech neck kind of idea is that people, it's almost a fear mongering type of, it's like you're telling people to tell someone that looking down at their phone is always bad for your neck is just not appropriate. Just being in any static postural position for too long, it's what we were talking about earlier. More of the focus should just be on moving more, not being stuck in one position, whether it's sitting for long periods, looking down at a device for long periods, whatever position. You just don't want to be static and sedentary for too long because any of those positions are more likely to cause pain as you're there for longer periods. You're asking muscles to contract. That tech neck is an example where you're looking down, you're asking your posterior neck muscles to contract to hold the weight of your head and to hold that. Or they're doing an isometric contraction. It's a contraction where you're not moving but squeezing. It'd be like if you did a bicep curl and you held your elbow at 90 degrees and then you tried to hold that for a few hours. Well, you're reducing oxygen to your muscles. That's reducing nutrient delivery. Eventually, those receptors in there are going to tell you that this is uncomfortable, and you'll move naturally. That's what your nervous system does. If a posture becomes uncomfortable, you just subconsciously move out of it.
Mm.
So I think sometimes people just aren't listening to those messages, though. Like they are scrolling on their phone. And we know all the dopamine and addiction things now being talked about with social media. People just get locked into that and they just are so absorbed. They aren't listening to their body. And I think, sometimes that, like I said, like any postural position you're in for a long period of time, it can cause discomfort after a while.
That's such an interesting point. Never the good and bad posture point. And so
Mm.
what is bad is just being in one position for too long. And that could be a yoga pose or the chronic neck thing looking down at the phone.
Yep.
So the solution is to move across a full range of motion more regularly and make it a everyday practice.
Yeah, and just like simple things, like just go for walks and things. I think I like to learn. I've really been interested in learning kind of like about hunter gatherers and looking at those communities and thinking about, I mean, that's a lot of where we came from. And of course, there was musculoskeletal problems back then too, but I bet you there was less of these sedentary problems. I mean, it's nice now that if we get injured or um, have an infection, we have medicine and surgery to help take care of those things. But it's almost like the heart disease conversation in a way. It's like these chronic things are more of the problem now. Heart disease and cancer is like the chronic problems are what get us more now. And I think in a way, in terms of the musculoskeletal system, almost the chronic problems are the sedentary problems. It's like we aren't so affected by these acute traumas anymore, but we're more affected by the fact that we just don't move. And sometimes I think just getting more I mean, I know for me during COVID, I I just had become more sedentary. I was working from home on the computer and I ended up just getting a watch so I could start tracking my steps, really just only for that feature because I realized my steps were so low and how much more achy my body would be when I wasn't moving enough. And so a lot of times for me, it's literally just thinking about those steps and am I getting 10,000 steps a day in? And it's amazing how just doing that, how good I feel.
Yeah, I mean, anecdotally, I can completely share the same experience. Something Eloise and I talk about quite a bit is it's so easy just to sort of that whole hustle culture, and you got to work, you'll be behind a laptop, you got to always be working, and then you've been to the gym, lifted some weights for 40 minutes, but you haven't moved. You haven't moved your body at all properly for a
Yep,
long period of time.
for
So
sure.
yeah, that step counts massive. And actually, I think this is I can see how they're sort of linked because if you're injured or in pain in some way that impairs you from moving, well, then you're at risk of all the sort of chronic stuff of the heart disease, of the cancer, dementia, all this stuff.
Yep. Yeah, that's why it's so important to address those impairments and get a program going so that you don't have the downstream effects of not moving. Because the movement is so huge. Besides your musculoskeletal system, just what you said, it affects your cardiovascular system. I mean, your mental health. There's all these other systems that are affected when people can't move because of pain or an injury.
So I'm like your classic, really guilty of just abusing my body in my early 20s. I used to play lots of rugby and then lots of sort of powerlifting stuff, really long distance running, and just slamming the pedal to the floor quite a bit. And for some reason, every time I do yoga or like some quite a reasonable amount of time for mobility, I feel calmer. Why does one feel calmer after these sort of slow movements?
Yeah, I think that probably a lot of it is that you tap into your parasympathetic nervous system when you're in yoga, which is that rest and digest kind of side of your nervous system. You've got sympathetic and parasympathetic. Sympathetic is the fight or flight kind of adrenaline, I'm ramped up side of things. And I do think this is one of the huge benefits of yoga, besides what it does to your physical body in terms of mobility and maybe strength, depending on the class you're taking. A lot of people, and this happens with Pilates too, I think a lot of people when they slow down and focus on slower movements, they tap into that parasympathetic nervous system. A lot of times breathing is incorporated into those practices, so people learn maybe better breathing patterns for sort of calming their system down. And then it also gives them the space, I think, to just pay attention to what their body's doing, like what sensations are going on, what is their knee doing during this particular movement. Sometimes there's a place for all these things, but I think sometimes in, powerlifting or running, some of these other activities, you aren't as it doesn't allow you to kind of slow down and really become aware of what's going on in your body and how you're feeling, as something like yoga or Pilates does.
Mm.
So you hear a lot of people who, when they practice like that, besides helping their physical body, it almost really helps their psychological side as well, just to slow down and, just just be able to breathe a little bit. Because everything is focused on that. Everything you see online right now is that kind of like hustle grind kind of culture, and it almost activates your sympathetic nervous system. It's like you're never doing enough. And so sometimes getting out in nature, I think, can be similar to like a yoga practice, something like that, where you can just get out and kind of slow down and just, like take it in. And yeah, I think probably the best way of thinking about it is just kind of being able to slow down and listen to your body a little bit.
I completely agree. I mean, there's something I'm trying to foster a bit more of, like slowing down on a world that is trying to get you to speed up. As somebody who talks quite quickly, this is hard for me, right? So something we're trying to work on.
Yeah.
Tom, with if you go back to the start of your career, how has your view changed on physical therapy, and what do you wish you'd known then?
Yeah, it's if you looked at what I actually do with patients in terms of interventions, it probably wouldn't look like it's changed a lot, but what has changed is my mindset around pain, and how much of physical therapy sort of involves psychological, almost like counseling therapy. So when I was new to this field, I came out of school really from this postural structural biomechanical model, it was called, where all pain was tied to something in posture, in your anatomy, in your structure, and in your biomechanics and how you're moving. And that was, if you solved those things, you'd solve all pain problems. But it just isn't that simple. A lot of people have pain problems that are more influenced by their mental health, things like depression and anxiety, by how much they've slept, what their nutrition looks like, how much inflammation is in their body. So I think over time, I've come to realize pain is a lot more complex. And with that, I have to think about all the different layers. Each person who comes in has a story and different factors that influence their pain. And you have to, and that's kind of where the counseling kind of therapy part comes in. I spend a lot of time talking to people now, especially if they're in more of a chronic or persistent pain state. If they just sprain their ankle, it's pretty straightforward. But if they have back pain that's lingered for a long time, and they have a 2 year more of back pain, then it is trying to kind of peel back the layers and figure out what other factors, what physical factors in their body, but what other factors outside of that might be influencing their pain. Because if I only think about their physical body and mobility and strength and all that stuff, they might never really fully get better, because I didn't talk to them about the other things that are they're the things that most people who come to physical therapy don't think I'm going to talk to them about: sleep or nutrition or their stress levels. So I think a lot of it is, I spend a lot more time now trying to listen to people and hear that kind of complete story. I moved out of taking insurance. So I don't take insurance anymore for this exact reason, that now sometimes I spend an hour and a half, 2 hours with people on the first visit. And sometimes the whole first hour is just them telling me about what's going on, and just asking questions and trying to figure out what the best way to move, what that looks like. How do I best move forward? Because sometimes the goal that I would have in mind of what I think I should be doing, as I talk to them more, I realize that's not at all their goal. And if I had just followed that route, they probably would have been really unhappy and not gotten better. In the same way that if I,
Yes.
spend more time talking with them and figuring it out.
So just so for the UK listener, a bit different healthcare system. Correct me if I'm wrong. You don't do you stop doing insurance, and the frustration was way too short. You don't feel like you can really serve the customer or the client, because the parameters of it are way too short to even have that time to understand.
Yeah, exactly. The insurance reimbursement here keeps dropping, so they're paying providers, paying healthcare practitioners less and less, and so because of that, clinics will require that their practitioners see more people. So it used to be that, maybe you'd see someone every 30 minutes. Some clinics have dropped down to like 20 or 15 minutes that you get with each person. So there's just no way you can really listen to them and provide good quality care. You're talking to them for a few minutes. You might do a little bit of manual therapy for a few minutes, then you send them off to an aide who does exercises. So you're not even doing any of the movement or exercise with them. And I was just frustrated with that. So a lot of years ago, I left. I was only in that system for 2 years. I realized it wasn't going to work. But um, so yeah, now in a self-pay kind of cash model, it's tough for people here because of course they have insurance a lot of times from their employer, and they want to use that to go see a physical therapist. But I think more and more people are realizing they just aren't getting good quality care there. And if you are outside the insurance system, you can spend as much time as you want with people and set your own rates. And it just ends up being, it's tough for the patient to spend that money, but they end up getting better way faster. Instead of going to an insurance clinic for 30 visits, they might come see me for 4 or 5.
Yeah, well, at an hour and a half or 2 hours a slot, you can really dive into what it is they want to do, right?
Exactly.
The interesting thing, just listening to what you're talking about just then, was this whole thing I've realized from doing this podcast, and Eloise and I learning all about health, and as we live our own lives, is you can't isolate one thing, and it's inevitably how you move is linked to how you sleep, and how you sleep is linked to how much you eat the next day, and you pull on one thread, and inevitably you get so many. So it doesn't surprise me when you say you have these sort of quite broad-ranging conversations, but upstream of a lot of that seem to be the basics. Seem to be how much are you moving, how much light are you getting, how's your sleep, and I think we can all get quite lost in that sometimes.
And I think that's why it's disappointing to people sometimes, because most people have heard all these things. They've heard like, oh, I should get this amount of sleep, I shouldn't eat these types of things. And the big problem for most humans is changing your habits. Like, it's an adherence problem. People know it's not a problem of information. Like, I mean, of course, there's a lot of bad information online now. Like, you have to have the right filters to find the evidence-based good information, but most people have heard these basic things. And so I think sometimes people are disappointed to know that it's more talk about the basic things, but it really is about it's really about kind of a consistent practice of the basics. That's what keeps you healthy, but it's boring to people. So it's tough if you're not sometimes, it's hard for me to fully understand because I've always gravitated towards health related behaviors. Like, I've always been interested in exercise. I enjoy exercise. I enjoy eating well and trying to get enough sleep, and I just like how it makes me feel. And some people just don't gravitate towards that stuff, or I think sometimes they just don't even know how good it could feel to dial all those things in.
Definitely.
So it's trying to help people understand that. Even I have a lot of family members who don't, and I'm always trying to convince them. Like my brother, I'm always trying to convince him of different simple health behaviors he could change, and I just imagine how much better he would feel. But he just, he's not interested in those things as much as I am, and so I can keep spewing information at him, and eventually he knows all of it. It's just trying to figure out how to create that behavior change. And I think this is what this is why there is a lot of psychology in all of this.
I mean, yeah, so many things come to mind. How you make a habit last and how you affect that change. I often think everyone falls on the spectrum somewhere between the world is completely plastic and the world is completely fixed, I can't do anything about it. And I think you need to fall somewhere sort of slightly towards the right of that, where the world is slightly more plastic, to be able to take your health into your own hands, to even believe that, yeah, you can do things, you can change your movement patterns, you can affect how you sleep, you can affect your hormone levels, whatever it is, your fitness. I know in the UK, that slightly older generation, like my dad's age, they very much fall on the other side, which is the world's quite fixed, including my health. My health is a predetermined path that will play out, which I don't think is necessarily true at all.
Oh, yeah.
Yeah.
Yeah. No, I agree with you. I think the older generations do tend to think that way. And maybe it's something that happens to you as you age. I think you have to intentionally focus on staying open-minded and being a little more plastic as you get older. It's like I can see where it happens. Life gets real and challenging things happen, and that can make you a little jaded and cynical. And I think you have to be aware of that and push back on it, because you're exactly right. I mean, something like this, the health of your body, and in particular your musculoskeletal system, you can make major changes throughout your entire life. I mean, we have lots of studies on this in people in their 60s plus, in their 70s, and being able to change bone density and muscle mass and mobility. I mean, you can change this stuff your entire life. So even if someone's never participated in it, there's so much good you can do by just incorporating a regular program. And I think going back to some of the building habits, I think sometimes for people it's making it social, or even just finding something that's movement related that you enjoy. Like, you don't have to, if you don't like going to the gym and lifting weights, you can do other things. Like, just at the end of the day, I think a lot of it, we spend a lot of time about mobility deficits and strength deficits, but at the end of the day, just try to find something that gets you moving. Like, just if you like tennis, like, and you have a group of people, find a tennis club and go join that, or pickleball, or like, just try to move, just try to get in a walking group. Like, it doesn't, you just have to find some entry point of something that you actually like doing that gets you moving. I think that's the most important thing. And sometimes it's having a social element, or just an activity that you actually enjoy.
So true. I think there's this definite shift from like solo wellness to social wellness. And actually the oblique effect of, I'm just going for a chat with friends and we happen to be doing, I don't know, a run or a walk or a cycle or rock climbing, sauna, whatever. But it actually is obliquely amazing for your health.
Yeah.
Tom, Dr. Tom Walters, that was so fun. I could talk to you all day, but appreciate you don't want to waste your time with the yo-yo.
We could get into the weeds on this stuff, that's for sure.
Yeah, 100%. And when you're in London, you've got to give us a bell, and we can do this in person. That'd be really fun. But thanks so much for your time. Really appreciate your work and your book, Rehab Science: How to Overcome Pain and Heal from Injury, is a really, really amazing and powerful read. I have read the Kindle copy. I'm looking forward to reading the physical copy, and I recommend it to our listeners for sure. Where can we find you? Where can we learn more about Dr. Tom Walters?
Well, thanks. First, just thanks so much for having me on. I love talking about these topics. I think there's just so many myths and misunderstandings out there about pain and injury and keeping the physical body healthy. So I always appreciate these opportunities to talk about all these topics. If people have questions or are looking for help with different things, my main two are Instagram and YouTube, and it's just at Rehab Science on both of those. So, and then the book, like you said, it's called Rehab Science as well. All of it is designed around, all of my information is sort of focused on different common problems that people have, different injuries, different pain issues, and then kind of the therapeutic exercises. Because that is the good news, I think, that if you have pain or injury, there are all kinds of different interventions out there, acupuncture, like there's manual therapy, chiropractic adjustments. But the thing that has the best evidence is education and exercise and movement. And those are things you can do on your own. So there's a place sometimes for sure. Like, I use my hands sometimes to work on people and do manual therapy. And so there's a place sometimes for that stuff. But once you kind of get past the acute stages, and, that's where exercise and movement comes in. And I think a lot of that you can learn online. You can learn in a book, and you can go do yourself. It's just about getting the motivation to do it. And hopefully, I think podcasts like this give some of the why behind. I think this is where these are helpful, because it kind of helps people understand, well, why should I be doing these things and incorporating them on a regular basis? And once people understand that and they have the resource, they can just start doing it. And it's amazing how powerful exercise and movement are for rehabbing injuries and pain issues and helping you not get them.
Well, I mean, it's definitely honed my why of, I'd need to, I want to move more. It's good. It's always a good episode when whoever you're talking to has inspired you to go and immediately just go and do the things that they tell you to do. So, Tom, thank you so much, and speak to you soon.
All right, sounds good. Thank you.
If you've made it this far, that means we owe you a massive thank you. Thank you for spending your time with us. If you found one thing valuable in this episode, please like, follow, subscribe, share with a friend, do whatever. It all helps the podcast, and we really appreciate it. Until next time, have a great week.